Welcome to our briefing on the expansion of mandatory managed care for seniors and people with disabilities. Thank you all for making time this morning. I think we'll have a terrific presentation and discussion today. We're going to try to leave plenty of time for discussion. In addition to this in-person briefing, we also have phone lines open. So we have about 100 people participating by phone. Theirs is in listen-only mode, but we're delighted to be able to offer that opportunity as well. In June of last year, the state of California, the Department of Health Care Services, began transitioning seniors and people with disabilities who are covered by Medi-Cal from its fee-for-service program to the managed care program. We anticipate that about 400,000 people are affected, and this is a very important group of beneficiaries to California, to the department, for any number of reasons. And one is that more so than many beneficiaries, they really rely on the program as a lifeline to some very important services, both traditional acute medical services, but also personal care, mental health, and a range of other services. So it's a very diverse and important group of people, and the transition is certainly gotten a lot of attention from a lot of people in Sacramento, but around the state. And it's not only getting attention here in California, it's getting attention at the federal level. Certainly CMS the Center for Medicare and Medicaid Services is very interested in the actions California is taking and looking to learn from those actions, both as other states look to transition their high-cost populations to managed care, but also in the context, as many of you know, of the dual eligibles, for whom both California and many other states would also like to transition to more organized systems of care. On the heels of a hearing sponsored by the Assembly and Senate Health Committees, which was I think probably many of you attended, a very interesting hearing about the early implementation experiences. We at the California Healthcare Foundation asked ourselves what more we could do to understand and evaluate the impact that this is having on the lives of people with disabilities and seniors that are making this transition. What's been their enrollment experiences? How is the transition going? How are they doing in terms of their health care? Are they getting the care coordination they need? Are they getting access to services? And we have been talking with our colleagues at the Department of Healthcare Services, a number of you with researchers at the University of California and elsewhere, and I've identified a three-pronged approach to examining this issue. And this meeting here and the work that Bobby and Karen, who I'll introduce in a moment, have done is the first piece of that prong, which is what can we learn on the ground, what's happening in counties, the activities, the implementation experiences right now. We don't have to wait. What can we learn in terms of what their experiences have been? The second prong will be a telephone survey of the beneficiaries themselves to understand what their experiences are. And we're working with Carrie Graham at the University of California and the Department of Healthcare Services on the design of that survey, which we hope to field this summer and have the results this fall, both to inform the ongoing care of seniors and people with disabilities that have made the transition, but also to inform the dual eligible transitions as well. And then the third piece will be some analysis of utilization and expenditure data. And again, we anticipate partnering with the University of California to look at claims, encounter utilization data, to really understand what impact it's having on the use of services and on health outcomes. So it's a multi-pronged strategy, and this is the first piece of it, and we're very excited to have the participants we have here today. Today's program, we have a presentation of findings by Bobby Wunsch and Karen Linkins, and I can't tell you how delighted I was that when I approached them about partnering with us on this study, that they agreed to do so. They bring a tremendous amount of experience and wealth and understanding and relationships to a study like this that's really important to getting it done and getting it done well and getting it done in a timely way. Many of you know both Bobby and Karen. Bobby is well, it's hard to pay attention to what's going on in the Medi-Cal program without seeing Bobby facilitating one meeting or another. But in addition to her facilitating work, she's also does a lot of studies, a number of studies she's done for the California Healthcare Foundation, but many other clients as well. Karen Lincolns is an experienced PhD researcher who's conducted numerous evaluations and really approaches this work from a very rigorous methodological approach, and really allowed us to take this from a collection of stories to a really interesting look at what's happening both in the counties that we were able to visit, but also in all 16 counties in which this transition is occurring. I'm also delighted that we have a great reactor panel, and everyone's bio is in your handouts, but I'll just introduce them briefly in the order that they will speak, starting with George Scolari, who is joining us from Community Health Group in San Diego, where he's the program manager for behavioral health services. George has been involved in behavioral health services for decades and really brings to this discussion today and his work a wealth of experience there and insights and relationships that I think we look forward to hearing from George. Following George will be Greg Knoll, who comes to us from the Legal Aid Society of San Diego, where he works on behalf of low-income populations and has a particular interest and has done a lot of work representing people with disabilities. And his work and the collaboration that both Greg and George have done together in San Diego, I think will be very illuminating for our discussion today. And then finally, I'm delighted that we have Margaret Tater, who is the chief of the Medi-Cal Managed Care Division and who is responsible for this implementation activities. Margaret, as many of you know, joined the state a few months ago from Cal Optima, and the state couldn't be luckier to have her because, as you know, Cal Optima is one of the health plans that has been serving this population on a mandatory basis for many, many years, and so she brings a lot of experience and expertise. So we'll have a great reactor panel following the presentation by Bobby and Karen, and then we want to leave plenty of time for questions and answers, and I hope you will engage in that discussion. A couple of housekeeping issues. One is you have evaluation forms in your packets. Please complete those. And that's a request that also goes out to those on the phone. When you got your call-in number in the slides for today's presentation, you also got an evaluation form. If you don't have those and you're participating on the phone, you can navigate from our website, chcf.org, to our Sacramento office, and there you will find some information about today's briefing and both the slides for today's presentation and the evaluation form. So please do complete those. If you haven't already, please turn off your cell phones. Last, I want to mention that next week we're having a briefing on the basic health plan, another interesting topic that's going to affect hundreds of thousands of Californians, and I hope that many of you can attend that. That's going to be on April 27th, on Friday, and again, you can find information about that briefing on our website, chcf.org, and navigating to our Sacramento office. Finally, I just want to mention that this briefing will be accompanied by a report, which Karen and Bobby are feverishly drafting and putting the final touches on. But one of the reasons it's not ready is we wanted to hold off until this discussion, because often these discussions can be quite illuminating in terms of what's most interesting to people, and we want to make sure that we address the questions that you raised today in that report. So be on the lookout for that in the coming weeks. So with that, I'm going to turn to Karen and ask her if there's anything I forgot, or my colleague Sandra, who no? Good? We're good? Great. Well, welcome, and I'm going to hand things off to Bobby.
Thanks, Chris, and good morning, everyone. I'm going to start the discussion off by presenting an in-depth review very quickly of the findings that we have collected through our work on this project. And our reminder to everyone that the focus of this project was really to understand the activities and the experiences in the local communities of all the local stakeholders, providers, health plans, community-based organizations, and community advocates in preparing for and implementing the transition of seniors and persons with disabilities into managed care. This was not a beneficiary study. As you've heard from Chris, that will follow in some subsequent months. I wanted to remind everybody that this transition of seniors and persons with disabilities into managed care happened in 16 counties across the state. Counties on the continuum of size from Los Angeles, the biggest, and Kings and Madera counties, the smallest of those 16 counties. So very diverse counties, very diverse experiences. Our process included an online survey, one for the 16 health plans that participate in the local initiative 2-plan model counties, and also the geographic managed care counties, Sacramento and San Diego. 14 of the 16 health plans responded. We also had a survey targeted at providers, community-based organizations, and advocates that was completed by 98 individual organizations throughout the state. A little less than half of those respondents were provider organizations. Then we chose 5 counties across the state to visit and talk in depth with the health plans, provider groups, community-based organizations, and community advocates in Alameda, Fresno County, Los Angeles, Riverside County, and San Diego County, again, representing the 2-plan counties as well as GMC. We also reviewed a lot of data from the Department of Healthcare Services and had discussions with the department. So as we go through this conversation today, I just want to highlight what we see as the main themes that we found in the work that we've done, and we'll look forward to hearing from you more in depth about those. There were many, many activities that many local stakeholders engaged in, some of whom have been preparing for this transition for 5 years. Unfortunately, though, it was very difficult as we went county to county and listened to stakeholders throughout these counties to correlate the preparation work with the outcomes. And as we'll talk later about choice rates and default rates, the only indicator that we currently have to look at the success of participation by the beneficiaries in choosing a health plan and then a provider, there's very little correlation between the two, and something that we'll talk about a little bit more in depth. We all know that we should have expected challenges to come. This is a very diverse population. It's not homogeneous. We know that the aggressive timeline from when the waiver was approved on November 1st of 2010 until the first letters went out to beneficiaries just a few months later. The timeline coupled, I think, with the nature of this population exacerbated perhaps many of the challenges that we see. We believe that efforts to engage particularly the fee-for-service provider community and beneficiaries directly was very limited and somewhat problematic. And we'll talk about that in more detail as we go through the report. And then, and not to be underestimated, consumer advocates and the health plans raised many questions throughout the enrollment process about the medical exemption request process and the continuity of care policies. So as we talk, you'll hear those issues raised over and over again. And now I'm going to turn to Karen Linkins, my colleague, to talk about the results that we learned both in the counties and through the survey, and then we'll come back and talk about the findings and some ideas we have looking ahead.
Thank you, Bobby. It's great to be here. It's great to see so many people interested in this topic because it is very important. And I think that we were very pleased at the response rate that we got to the survey. The survey was administered, as Bobby mentioned, to all 16 plans across the counties, and 14 of them did respond. And for the other survey, we actually took a kind of a viral approach to it. So we started with a core set of entities that we knew would be appropriate to respond to the survey, and then we asked those entities, in addition to responding, to pass it along. And so from that, we got almost 100 responses from organizations. So it's I think that this is a very good temperature taking point where we've gotten some very good feedback. It might not be as specific as possible, and that's what we want to hear from you all. So I'm going to be running relatively quickly through the survey results. This is not all of the survey results. You'll see more in the report, but these are our highlights. So the first set of slides that I'm going to be presenting are related to the health plan activities, and we asked the health plans what they did to prepare for the transition. And this was we asked them both in terms of what they did themselves for their staff as well as for their provider network. And then we also asked them about their beneficiaries. So in terms of what they did to prepare for the provider network, or prepare the provider network and prepare their staff, 90% of them, there was a lot of convergence here, 90% of them actually said that they, conducted the facility site reviews, they analyzed their claims data, they attended the DHCS informational meetings, they did a lot of education and training for their staff and for providers, and they collaborated with other stakeholders. So probably no surprises there, but I think it's very interesting that almost all of them said that they engaged in these activities. And then we asked them what they did to prepare the beneficiaries. And here you see again, high rates of convergence here. They collaborated with stakeholders, educated their staff, developed and disseminated written materials that augmented what the state was sending out. And then they convened cross-organizational work groups to identify problems and, create some fixes for those problems. And then they also conducted informational meetings in the community to augment the meetings that were sponsored by DHCS. We also asked the plans there were the two surveys. So there's the survey that went to the plans, there's the survey that went to the providers and the advocates. And we asked them to give us some feedback about the DHCS sponsored activities, and that's what the next two slides are. So this one was asking them, did you participate in any of these activities? And you can see that on the health plan side, a very high number of them reported that they participated in these activities. So that included attending the county presentations, using materials from the website, and participating in webinars. What you see on the right-hand side regarding the providers and advocate organizations is a little bit of a difference. First of all, not as many said that they participated in or used these sources. When we dug a little more deeply into the data, what we found was that the advocates and the non-medical providers actually participated in these activities more frequently, or they reported, more of them reported participating in these activities. The fewest number of participants were the medical providers. And when you slice that even more, the specialty providers were not even present. I mean, I think it was fewer than 10% of the specialty providers accessed any of these sources. And then in terms of the utility of these sources, again, you see this pattern with the health plans where, an awful lot of them reported that they found the website and the webinars useful, but it kind of starts to fall off in terms of the utility of the county presentations and the beneficiary mailings. On the provider and advocate side, you see a similar pattern with actually fewer than 40% saying that the county presentations and beneficiary mailings were useful. And when you think about that in the context of the medical providers that actually did report that they knew of these activities or they used these sources, that's actually an important foreshadowing of some of the things that we heard in the counties related to the lack of connection to the provider community. We also asked the health plans to tell us about what they considered to be the most effective strategies that they used, as well as the least effective. And this is related to reaching providers. And what they reported was that in-person meetings and information sessions, including meetings at providers' offices, were the most effective. And the least effective were the more passive, written communications, FAQs, newsletters, that sort of thing. And this is a theme you're gonna hear from us this morning. Basically, what we have found, both for the provider community and the beneficiaries, is that the most effective outreach was actually the high touch, in-person, personal, that sort of connection versus more of the passive town hall, large meetings in the community that were, kind of impersonal and people didn't connect to or they didn't know about, and also written communication. In terms of challenges, we asked the health plans to tell us, why it was hard to reach providers. And what you can see here is, a basic pattern of issues related to unclear policies or changes to policies, and also issues with the DHCS training materials, and then a lack of coordination at the state level across the different participating entities, such as DHCS, Healthcare Options, the Ombudsman, et cetera. And then there's kind of a fundamental issue here that we address in the report. That is the fact that the provider community is very heterogeneous. It's very diverse. It's not centralized. So for the providers that were not really known to the health plans, they were very hard to reach, and there's a big disconnect there. And then we asked the plans to tell us about obstacles that they experienced reaching the beneficiaries. And here you see an issue related to contact information. This shouldn't be surprising to anybody. I think that this comes up again and again, but the first two items here, incorrect and incomplete contact information, and then the lack of responsiveness on the part of beneficiaries, those are both probably highly correlated and linked. And then there was also the issue related to the brief timeline for communication, as well as the unclear policies. We also asked, and now I'm switching surveys, so I was talking about the health plans, now I'm going to talk about the provider advocate surveys. On this, we asked the providers and advocates about their activities to do outreach to both providers, but also primarily to beneficiaries. And what they said was that they trained staff, they attended trainings, disseminated written materials, they provided telephonic or in-person counseling sessions. And then if you go to the bottom of the list, what's interesting here is about 10%, and we actually, we know that it was primarily the medical providers. They didn't do anything because they either weren't aware of it or they didn't know what to do. We also asked the providers and advocates to report the challenges that they had that affected the effectiveness of their outreach activities. And these included, the top response here was confusing or incomplete information communicated to beneficiaries that created questions for providers. And so these are the providers saying, people came to my office with their letter, they didn't know what to do. And it created a domino effect for me. It was burdensome, and it was a problem. There's also this issue of the short timeline, the unclear or changing DHCS policies. About a third of them reported difficulty collaborating with health plans. A third reported difficulty knowing where to get answers from the state. And then you see that issue of the inaccurate contact information being a problem as well. And we asked the providers and advocates to share with us what they thought were the most effective strategies, as well as the least effective. This completely echoes what I presented before with the health plans. High touch, in-person or kind of personal telephonic support was the most effective, and also collaborating with the health plans and the CBOs, really having that community approach to addressing the transition issues was considered effective compared to the impersonal town hall type forums and the mailings. And now I'm going to pass it to Bobby.
And for those people on the telephone, we're on slide 17. And we're just now going to summarize again the findings and what we would suggest in terms of looking ahead. So perhaps the best summary of the findings is there were really no surprises as we looked across. The concerns that people had were borne out. and the ability to measure the success of this program so far, it's too early to know whether the effort has been successful or not. I just want to emphasize again that there are some amazing, intensive examples in a number of the counties where there was great collaboration between the health plans, the providers, and the consumer groups. I think you'll hear from San Diego in a few minutes. I think a great example, Riverside County and Los Angeles County certainly also stand out in that effort. But as we said, with all the time and effort that many of the health plans put into preparing, we don't see the results in the choice rates or the converse, the default rates. And perhaps that's not the best measure of success, but it's certainly one of the few that we have. It's been very difficult to assess whether the transition met the goals that were set out. I think in part it's too early, and in part, although the department created a great dashboard to follow the enrollment effort, no one created any targets. So we don't know if 3,000 MERS, medical exemption requests, is a high number, is it too high, or in fact, is it too low, and should more people have applied for exemption requests? We don't really know, because we didn't have a target, what the best choice rates would be, or what our target for success would be. So I think in going forward, it's important to translate the goals of the program into some measurable benchmarks or targets that we can use to evaluate the program in a more adequate way. As Karen has said, and as we'd like to re-emphasize over and over again, experience in other states and in the literature, and certainly in talking to all of the stakeholders in California, I think bears out, that high-touch outreach efforts and intensive navigation and personalized attention correlate highly with increased choice rates and satisfaction with the system. And that's hard to do in a very short time frame. We've mentioned, and we want to underscore again, that the efforts to engage providers and beneficiaries were limited, and they were partially limited by the time frame, they were partially limited by the nature of the system, but particularly efforts to reach the many fee-for-service providers, particularly the high-volume fee-for-service providers, including DME providers and pharmacy providers. It was very problematic to reach them, and conversely, the concerns raised in each of the counties with continuity of care with those providers came up over and over and over again. We all know that we would have hoped for more intensive outreach to beneficiaries in terms of the limited state presentations in each of the counties, and even where the health plans and the consumer advocacy groups went further in terms of presentations, only a small number of the beneficiaries were reached, and perhaps a different approach might have been to target, again, high-volume provider groups and even high-volume utilizers to get started in a personal, one-on-one effort, county by county. The inaccurate information in the contacts created problems for healthcare options as they tried on multiple occasions to reach beneficiaries, and then that inaccurate contact information was passed on to the health plans, who then in turn had difficulty reaching the members. One of the things we also noticed was, even though there was a lot of training at the individual health plans and with many consumer groups and community-based organizations, in addition, the state-sponsored training with all of the health plans, there was a very limited focus on the mental health needs and the mental health conditions of this population. And I think we probably all have underestimated the impact on reaching the beneficiaries of their mental health situations. In addition, an issue echoed over and over again by consumer advocates and by the health plans were the changing clarity around the medical exemption requests and the continuity of care policies, and a lot of questions raised about technicalities in the applications for medical exemption requests. So very difficult to couple the medical exemption requests, the continuity of care issues, with recruiting providers who are in the fee-for-service sector now into the managed care networks and into the managed care plan discussions. So as we look ahead, a few thoughts and perhaps some new opportunities as we go forward. So perhaps first and foremost, having a longer transition period before the actual mandatory enrollment begins would have been helpful. And if you look back, and even though we started these discussions 9 years ago, for those that are old enough to remember, and many of the plans, as I said, actively have been working on this issue for 4 years, 5 years. When the bell struck on November 1st of 2010, there was a race to the finish line to get to March when the first beneficiary notices were distributed. That's not a very long period of time. And then from when the first beneficiary notices went out until the first people were enrolled in June, not very long. And even though the beneficiaries have been enrolled based on the month of their birthday, so the enrollment has been staggered, which certainly was helpful, it just wasn't enough time to get as many people as possible educated, connected, talked to throughout the process, and here specifically providers and beneficiaries. I don't think we can ever underestimate the need for simplified materials, and both the state and many of the health plans and consumer groups came up with their own simplified materials. When the enrollment packet, which is as big as a phone book, reaches your front door, sometimes doesn't fit in your mailbox, sometimes gets lost in the shuffle of those big mail packages, how can we continue to simplify the materials, provide clear and concise policy and policy interpretations for the entire process, and how can we make sure that the data, first starting with the contact data, the initial contact information, but also all the data that was transmitted by the state to the plans, is accurate, easily accessible, and useful so that the plans and the beneficiaries can get connected as quickly as possible. We've already mentioned the need for more personalized, high-touch, most of that meaning face-to-face, in-person, or telephonic communications, both with beneficiaries and with providers. A focus, we think, on, at least to begin with, on high-utilizing beneficiaries, and there's data about them in the claim system, and high-volume providers, at least starting at the point where we know we have the most serious medical and mental health and other health conditions. Start with those people and make sure that they're hooked up to the right providers, that their services and benefits can continue. I would say we'd also suggest that not enough was done and much more can be done to harness the local infrastructure in every community. The local community-based organizations, the local advocacy groups, obviously the local providers, who could work directly to help educate the beneficiaries. And again, particularly the beneficiaries who have the most contact with the system. We'd also suggest that there be some kind of grace period, and a couple of the health plans did do this, a grace period after enrollment and before provider changes are made or before benefits are changed, so that the plan has time to meet the beneficiaries, talk to them about what their needs are. And the attempt at that was done through the health risk assessment, but a large majority of the beneficiaries didn't get risk assessments, and there was a time lag from one day to the next when people needed pharmaceutical supplies, they needed DME supplies, and so on. In addition, as we've mentioned, it would be helpful to identify and measure changes in utilization patterns of the beneficiaries, look at health outcomes, and look at patient satisfaction among the beneficiaries. So begin to dig more deeply over time about what's really happening to these people as individuals and how their health status and how their health conditions are improving, remaining the same, or going in the wrong direction by nature of these many changes. So we had, and just want to acknowledge an advisory group that we had as part of this project, and thank them for their constant diligence at helping us refine questions for the survey, refine our thinking about the issues, and in general, shepherd this project along. So thank you.
All right. Let's start things off with George Scolari. As I mentioned, George is joining us from Community Health Group in San Diego, where he has been working on behavioral health services for many, many years. And he and Greg and others collaborated quite a bit in San Diego. I think, as you heard from Bobby, one of the counties where both Bobby and Karen saw quite a bit of collaboration in terms of both the planning for this, for the implementation of this transition, as well as the implementation of it itself. So, George.
Well, thank you for having me. Again, I'm George Scolari with Community Health Group, a local not-for-profit health plan in San Diego, and really representing all of our San Diego Medi-Cal managed care plans. So briefly, I'll tell you a little about how we work as a GMC. Beginning in July of 1998, we started Healthy San Diego, which is the umbrella in which the 5 Medi-Cal managed care plans operate. It was 7, it's now 5, but 3 of us are the originals. Greg Knoll from the Consumer Center was very instrumental in starting Healthy San Diego. They started back in 94 creating it, but we actually kicked off in July of 1998, and that's when I got involved. We have a wonderful structure with a joint consumer and professional advisory committee, and again, Greg is the chair of the consumer side of that. Underneath that is a QI subcommittee, and then probably 10 different work teams. It varies, but it's 8 to 10 different work teams, very, very active. All the health plans get together, not once in a while, but several times a month, and several times a week lately, with the new duals coming up and the SPD transition, which is still going on. I think we're talking a little bit about something that happened starting in June of last year, but it's not over with yet. We still have a lot of work to do. You know, the remaining is just as important as the beginning. So what we decided to do when we knew this was going to happen is we took some of our very active work teams that require lots of people, like our behavioral health work team and our regional center work team and our provider education work teams and our site evaluation work teams, and kind of form a master work team we called the SPD work team, which I chair. And we had a kickoff meeting on February 23rd of last year, and 53 healthcare leaders in San Diego showed up. It was a 2-hour lunch meeting. And it was really 53 people that were mostly CEO levels that could direct their departments and staff to kind of do things. So like for our Health and Human Service Agency, it was the heads of our HHSA and then the heads of Aging and Independent Services and the director of our county behavioral health, along with his director of EQI and medical director and the CEO of our regional center. It was just everybody, all the health plans, even our friends from Inland Empire Health Plan came down to see what we were up to. And out of that meeting, we thought the most important thing we can do collaboratively, because in San Diego we are so collaborative, is really get out there to the community and educate them and tell them not only what's happening, but who the plans are and how to navigate it, because we really, Medi-Cal managed care plans do a really, really good job at coordinating care and making things happen and making sure our members get the care they need. But if you don't know how to work the system, things fall apart. So we went out there and reached out the very best we could. We did, I think, 42 SPD Medi-Cal Managed Care 101 trainings in San Diego last year. I represented the health plans, not my company. The rule was I could not say who I actually worked for. My name was George Scolari. I worked for Healthy San Diego. Wore Healthy San Diego shirts half the time. And it was either Greg Nall from the Consumer Center or one of his managers, Carol Nidenberg, who oversees mental health at this agency. And we went out there, set up these 42 trainings. Most of them were by request. You do one training and then you get 10 emails wanting more. We trained a whole lot of consumers. One presentation was 62 seriously mentally ill clients that showed up, and it was at their request. We went out there and they came in kind of angry about this change. They were being forced to do something, and they left thinking, man, I think I'm going to get healthier and have a lot better care. Somebody's going to look out after things. Regional Center, the CEO of Regional Center said, I want every single social worker to be trained. So we did 4 regional trainings for them. They have 4 offices. 278 of their social workers learned everything they needed to know. And what Greg and I especially did was throw out there the challenges, the things that might not work for them. Like they're used to sending all their clients for this particular thing to this particular place, and none of the health plans contract there, but we were trying. And this is how we can fix it. This is who to call. This is what to do. So really the message was collaboration. We really worked together and we think we made a big difference. We're still doing it, we're not done, and then we get to start all over again for the dual demonstration project. But I think the thing I was most proud of is just how our county came together and how close our health plans are. And probably most important is our relationship with our advocacy agency, the Consumer Center for Health Education Advocacy. Almost every single problem we have with our members who call them, we did not know about the problem. We learned about it from that call. I'm not talking about a lot of calls. We get 2 to 3 phone calls to the Consumer Center each health plan every 3 months. That's it, even with the SPDs moving into Medi-Cal managed care. But most of the calls are them telling us, you have a problem and you don't know about it, let's get it fixed, and we do.
I want to thank you for a really good job in the investigation. I think it's a fair representation of our key challenges. The findings will really help us figure out next steps, and I think not only to improve this program, but provide us lessons that must be taken into account with the dual eligible transition. I'm going to focus on the lessons learned and how we might define success for ourselves in the future. There's 3 major challenges: timeliness for implementation, ensuring consumer protections are realized, promoting meaningful consumer education and assistance. I don't think there's any dispute anymore from the findings here that the implementation timeline by DHCS was too aggressive. How do we take that information and build in a more realistic timeline that Bobby was talking about, maybe a 3-month transition for health plans to get folks from fee-for-service to managed care? The benefits of managed care, and there are many, can only be realized if the plans are given sufficient time to make this transition happen. And it has to be built into the system. 2 of the key consumer protections to prevent delays in meaningful access were the continuity of care and medical exemption request. I think this report again should lay to rest that there's a dispute that DHCS did not sufficiently promote or support these protections. Though the continuity of care requirements held the plans responsible for negotiating specific contracts on behalf of the consumers, DHCS provided inconsistent information about the scope of the responsibilities. Now, to DHCS's credit, they ultimately put into place the procedures that ensured a smoother transition with regard to medications and things like that. But based on this experience, we can't recommend strongly enough that in implementing the dual eligible transition, that all continuity of care protections be clarified in advance and with the input of plans and consumers. The medical exemption request process has been undermined by DHCS in a variety of ways. The CHF findings identified the fact that both plans and consumers repeatedly raised concerns about the MERs, and that the unclear and changing policies by DHCS resulted in a challenge to the effectiveness of the transition. We need to learn from this experience so that we never again see protections only on paper. While the regulations on medical exemption requests provided a clear definition of what conditions should qualify, it left open other conditions that were substantially similar. DHCS repeatedly took the position that if a continuity of care contract could be provided instead, then it would reject the medical exemption request, inconsistent with the clear meaning of the regulations. The regulations requiring medical exemptions again define the qualifying conditions, but also contained language indicating that a transition could be made to managed care if the patient was stable. DHS adopted an interpretation which inverted these requirements to deny the request if a finding that the patient was stable could be made. Again, inconsistent with the clear meaning of the regulations. Now, let me be clear. Consumer advocates have had our successes challenging these interpretations by exercising appeal rights. However, at a macro level, we'd like to see the protections that exist both on paper and through the agency's implementation of what is on paper, without depending on individual appeals. As the dual eligible transition occurs, let's get it right this time. Whatever protections are created for medically vulnerable individuals need to be respected and protected. Consumer information, engagement, and assistance. The report details findings about what works and what doesn't. Written information, web-based information are the least effective. The most effective way to work with consumers is in person. Opportunities for individual assistance and deep collaboration with health plans locally and community-based organizations that touch consumers' lives. Consumers need to work with organizations that they already trust, and those organizations need to be supported in working together to identify local solutions. This report notes that the state agencies were ineffectively coordinated and that beneficiaries had difficulty getting answers from the state. As an alternative, we would suggest that DHCS promote, much like the Department of Managed Health Care, contracts for consumer assistance models that work locally, providing local advocates throughout the state that can provide a range of assistance with individual problems and use that experience to address systemic problems with the department. How do we find success in the future? Evidence that consumers are actively choosing their plans and providers, evidence that the transition for consumers does not result in disruptions in care, evidence that care coordination is available and utilized, evidence that consumers have avenues for assistance that are effective, and local collaborations that promote opportunities for plans and consumers and their advocates to share information about problems and work together to adopt solutions. This report makes clear DHCS needs to show that its role can be trusted, to adopt a realistic time frame, to be held accountable for supporting key consumer protections, and to be accessible to stakeholders that raise real problems.
Turn things over to Margaret Tater, Chief of the Medi-Cal Managed Care Division.
Well, thank you. And thank you very much for inviting me to participate on this panel and to spend a few minutes responding to and establishing some of the key reactions and identifying the key reactions that seem certainly most salient from today's presentation and that seem to be critical for purposes of everything that we're doing on a go-forward basis in the department. A couple of preliminary comments or reactions, and I'll try very hard to respect the time so that we can get to Q&A. I think we've talked about the report and the findings, and then, of course, the reaction to the report and the findings in the context of the SPD transition. And a lot of what we're talking about has to do with a snapshot in time of what happened in a certain period of time in connection with a certain transition of populations from a fee-for-service environment to a managed care environment. Certainly, as everyone has acknowledged, there are lessons to be learned. I think, however, from my perspective, and this comes from the perspective of one, as Chris identified at the outset, I have only recently come to this state. My prior experience was with a health plan with CalOptima. I think on a certain level, my reaction to the findings is a reminder to myself, and I think to all of us, that these lessons aren't really lessons about a transition per se, but they're lessons about how we have to operationalize a lot of what we do at the department through our health plans and through the providers that serve our members. So for example, when we talk about the need for enhanced clarity in beneficiary communications and in notices and in information about the transition, it's really more than just a transition, and it's more than notices and communication in connection with, for example, what we're doing now in connection with the duals pilot program. I think one of the key lessons is that this is a challenge that, you know, exceeds a particular transition, a particular initiative. So for lessons learned, I think that a lot of what seems critical from my perspective is that these are lessons to be embedded and operationalized in a lot of what we do on ongoing management. I'm particularly grateful to the presenters today and to the reactor panel for the help and guidance in terms of what works, as well as all of the things that have been problematic. I mean, I think it's absolutely critical to kick our tires, to make sure that we understand the things about the transition or anything about oversight and how we manage the program could be improved. But I think it's also really, really helpful to get guidance about specific outreach strategies, particular engagement strategies that are successful. So with that, a couple of things that seem really critical for today's discussion, for the ongoing work of the SBD transition, and then as the panel has talked about, for some specifics about what we're doing in connection with the duals demonstration program. Lessons about beneficiary notices and communications heard loud and clear. The beneficiary communication and engagement strategies have to be improved. We see it as very much a multifaceted issue, though. Not only do the notices and the materials and all of the things that have to get done have to get improved, but we see the challenge as one of true communications and outreach, and as people have talked about, that's also critical to happen at the local level. To that end, in connection with the duals work, for example, we're working right now through a work group process. We had our first work group of all of the work groups that have been set up for the duals demonstration program. One of the themes in last week's inaugural work group on beneficiary notice and communications had to do with this very fact, that yes, we have to do a better job in terms of clarity around the enrollment process, clarity around enrollment procedures, clarity around the notices and their content, but we also really have to have an overarching approach to a communications plan, a communications strategy, and we heard loud and clear from that work group that that's a local level process, and that we really need to do a better job, for example, in the duals arena, to make sure that the selected duals demonstration plans understand that imperative. Similarly, in the category of provider outreach and engagement, you know, as I said at the outset, the imperative that we engage with providers really is one that's probably going to transcend a specific initiative or the SBD transition or the duals demonstration program. I think that, you know, we've learned and heard loud and clear that notwithstanding the fact that our health plans contract and engage with the provider communities at the local level, here at the state level, we can inform that and we can enhance that process, and we can certainly at least attempt to engage statewide associations, statewide stakeholders, provider organizations of which they're a member, to really make sure that those processes are in place so that the plans, the networks that are developed, the delivery systems that are designed have in place the kind of provider networks that will ensure success. So we've heard that loud and clear. Another issue that we've heard loud and clear, and we are struggling with this, and we are trying to figure out the best way to address this. We've heard loud and clear, plans need data. They need the member level data. They need it accurate, they need it faster, they need it in advance of the members being enrolled. We've heard that. I mean, we, as everybody in this room appreciates and knows, we have the challenges of HIPAA, we have challenges of making sure that we're compliant with HIPAA, but we're working on that, and we're working on that through the work group process right now and the duals demonstration program. A final word about coordination. I think all of the reactors have said it more eloquently than I can. Everything about what we do in a managed environment is about collaboration. We at the department level, we have an obligation to really make sure that we're working with all of our sister departments and agencies, and then ensure that our plans model that at the local level. So we've heard that loud and clear, and look forward to making sure that that happens in the dual demonstration program. Thank you very much.
Thank you, Margaret. And thanks to all of our panelists for joining us today and adhering to the strict time limits that I gave them. I know it's very difficult to keep comments within 5-minute time frames, and I especially appreciate George and Greg, who came all the way here from San Diego, I often feel embarrassed to say, hey, would you mind taking a whole day, flying up from San Diego and returning for a 5-minute presentation? But they were gracious enough to do so with the promise that your questions would engage them further and give them another opportunity to share their successes and challenges in San Diego. So with this, I'm going to turn things over to you all. It's a reward for finding this room, which certainly challenged me, and I'm sure those of you who were more experienced here had no trouble finding it. But questions from, yes?
I think the important thing is for the community, the department, the advocates, the health plans, the providers, to set our own goals, though. And I think if we could set some goals and put some quantifiable measures to them that we agree about in advance, so that we know if we at least got to where we hope to get, whatever the number is, in whatever the categories are, I think that would probably be the most effective way to move through this.
I will just add that we recognize how difficult that can be. And I want to give an example. We are just actually finishing up a survey of Medi-Cal beneficiaries. This is not just the SPD population, but this is the broader Medi-Cal population, survey of 1,000 Medi-Cal beneficiaries, asking them a number of different questions. It's actually it's a survey that we last conducted in 1999, and I'm not aware of any survey of this scale that's been conducted of this population since then. So we're quite excited about the results. But we ask a range of questions, and one of them, a series of the questions have to do with access to care. And the question has come up as to, okay, we ask people, are they able to find a primary care provider? We ask them if they're able to find a specialist. But what number are we hoping for? If 80% say they can, but 20% say they can't, is 20% too many who can't find a specialist nearby them? Should that number be lower, or should we be delighted that it's only 20%? So we fortunately are able to benchmark that against a survey we did with the general population. But even then, it gets a little fuzzy. We were talking with some researchers that are advising the federal Medicaid and CHIP Payment and Access Commission and asked them whether or not we should be comparing access to care for Medi-Cal beneficiaries to the general population. There's a federal law that says access has to be equal to the general population. Or should it be the general population of people at the same socioeconomic status as Medi-Cal beneficiaries? And there's big differences in access. And the answer is the MACPAC Commission, this federal commission, doesn't know what that right answer is. So it goes to show that even some of the brightest and best thinkers at the federal level are struggling with this. Okay, we've got the measure, but we're not actually sure what the target should be. So I just wanted to share that and
Chris?
Plug the report while I'm speaking. Yes, Greg.
I wanted to piggyback on what Bobby said. You know, I'm all for measures and, data drives the world. I got that. But, doesn't a lot of what happens with data depend on the sort of interreliability of all this? I don't know how many MERs are right, but I'll tell you this. If all the UC systems aren't going to contract with health plans and aren't going to be part of it, maybe 100,000 is the minimum number of MERs, not 3,000. However, if we get them to contract and we do have a community that's accountable and they're included in it, gee, maybe we'll have 0 would be the right, MER. I mean, so a lot of these problems are interconnected. You solve one, you might be able to get to the issue of what's the right number of MERs. For me, it'd be 0, because that means everything's perfect,
Great point. Did you want to, anything to? No. Yeah, great. Okay, in the back here.
What I'd like to take away today, if any of the panelists could give some forecasting substantively about, I understand that the assisted living Medi-Cal program for long-term care will be merged into or become part of managed care?
That's a great question. A couple of things, and I will definitely touch base with you after the presentation. Currently, as we've alluded to in the presentation today, the department, the state, along with CMS, is involved in developing what we refer to as the Duals Demonstration Program for California. 15 other states are working with CMS to develop Duals Demonstration Programs. To that end, there is a proposal posted which outlines how the Duals Demonstration Program would work in the state of California. By way of process and procedure, we, the department, have posted the Duals Demonstration Proposal for an initial 30-day review period, and I'll get you the website address. After that initial 30-day review process, when people comment, suggest input, suggest additional things for consideration on the proposal, we'll take it back, we'll revise that proposal, and then we post it for a second round of review and comment period at the federal level. So in the context of our proposal to the federal government for this Duals Demonstration Program, we are proposing that in the selected counties that would be our demonstration counties, 4 have been selected. We're suggesting that the care for all of the beneficiaries, substantially all of the beneficiaries who would be enrolled in those programs, would be coordinated through a plan. The plan is, and I'll show you the provisions that address some of the waiver programs. The plan is that all of those services would be coordinated through the plan. But there's lots of parameters about that, and I'll definitely follow up with you. But again, we are in, for purposes of process and notification to everybody in this room and on the phone, we're in the first round of review and comment, and perhaps by way of follow-up, we could post the notice with the materials from this meeting just so that everybody has that. And I'll follow up with you. Thank you.
We had a question in the third row here.
I guess my question would be, how can we, given the challenges you've brought up about your interview process, how can we get that information in terms of the current SPD population, and how can we monitor it going forward?
Well, I think, and we've had conversations about this, so that's on the department's radar, it's on my radar, and I think that, what we need to do is really, continue to work through the work group process and continue to, we have your comments, and I would urge you to make those comments and just make specific recommendations in connection with the proposal for how we should monitor that. The transitions are always challenging, but there are things that we can do in terms of requiring certain kinds of data from our participating plans, requiring certain kinds of interventions, and then monitoring that. But it's always, the transitions are always going to be a challenge, and we have to monitor that.
And I would just add two ideas for ways that we can address that. One is the review of the utilization data. There will be a pre-post comparison, so you can look to see if there's been a drop-off in utilization of those services, and that's one way. And then I mentioned this telephone survey with the beneficiaries themselves, and we will supplement that with some focus groups. So I I appreciate your comment, and we will, when in the design of that survey, we'll flag those post-acute home and community-based services as an area that we're certain to explore.
I was wondering how fiscally realistic it is to recommend that health plans provide substantially more high-touch contact with beneficiaries.
I really think, you know, I was talking to our medical director about this yesterday at our health plan. I think that a lot of the stuff that we've had to learn to do, we were already doing. Like at my health plan, we had approximately 8,000 SPDs moving into our Medi-Cal managed care plan, but we already had 3,000 of them who had voluntarily enrolled, plus we have a Medicare DSNP program, special needs program. And so I think we've learned over the last 4 to 10 years to do a lot more hands-on than we used to do. You know, we have much better access to our members. Our members know who to call. And I'm hoping the same feeling will happen with a dual demonstration project, because that's going to be even a lot more, because now we're starting to look at doing things we've never done, like coordinating or paying for in-home supportive services, the new community-based adult service programs, formerly ADHCs, a lot of new stuff, a lot of new relationships we've never had, like with aging and independent services. In San Diego, the last year is just focused on AIS, Aging and Independent Service in San Diego, and it's a huge agency we've never communicated with before. We've known each other, but it's kind of this SPD's moving into Medi-Cal managed care in many ways has been a good thing, at least for us in San Diego. It's developed new relationships, and we are doing more slowly. What's nice about the every month new members is you slowly start doing more and more hands-on, and it becomes a way of doing business, I think.
Certainly the question about finances and the ability to do all of the things that we want to do is certainly relevant. But from my experience at Cal Optima and working with a lot of the plans, there really are a lot of things that plans can do that you know, really do reflect exactly what you're saying about getting embedded in the communities that you serve. There are ways in which the plans can work with the local aging services community, the ways in which they can work with the county agencies that touch the members and the caregivers and the families of the members. It's about really rethinking critical relationships at the local level. To that end, it predated my arrival at the department, but to that end, in connection with the request for solutions that the department, in collaboration with Department of Social Services and Department of California Department of Aging, put out for the duals program, we specifically asked applicant plans in that document and in the interview process to talk about those relationships, to talk about the extent to which the plans are authentically connected in their local communities. So, do you work with your local Office on Aging? Do you know where it is? Do you know about their schedule of community events? Do you work with the IHSS Advisory Committee in your local agency? Do you know the people and agencies and community-based organizations that similarly touch your beneficiaries or members and the families that you serve? So I think that it is perhaps a paradigm shift in some areas, but it's a way of rethinking community outreach and becoming completely embedded. I think really it's exactly what you were talking about in connection with Healthy San Diego.
I think I just want to add to that. I think it's you know, knowing who all these agencies are is one thing. Really knowing the agencies is another story. So being able to say as a health plan, oh yeah, we refer our members to the consumer center, let me look up their phone number, versus do you want their 800 number or Greg's home number? No, really knowing the agencies, and I feel that's what we've done in San Diego. It's not fake, it's not just, you know, it's real, and it's making a difference in the lives of these folks we're here to serve, I hope.
Last comment on this.
Yeah, I just wanted to add, I think it was a very good question. I think many of the health plans have experienced already an intensified interaction with the seniors and persons with disabilities, their new members. And I think all of them are beginning to think about the fact that investing in those members in the beginning of the process, early on, is like investing in prevention. It pays off over time to invest in high-touch interaction with these individuals to prevent more costly, more intensive care and situations later on. And I think we have to look at this way, because the only way, I think, to work with these individuals with complex situations is to connect to them early in the process, understand their needs, help them navigate the system, and get them to the services they need before they end up in a situation where they need more services, more costly services, and are in situations that are, frankly, so complex and so complicated that solutions may not present themselves.
And I just wanted to add briefly that we've been focusing on what the health plan's responsibilities are and the relationships, but let's not forget something that Greg raised, which is the notion of consumer assistance in the implementation and planning. And I'll contrast this with the implementation of the Medicare Part D benefit and all the investment that was put into educating and informing and providing an avenue for beneficiaries to ask questions. And that was one benefit, very important benefit, but one benefit. This is about all of their benefits. So hopefully with the duals, where there is a greater federal ownership viewed by Washington. I don't quite understand why they don't view it quite as strongly with this Medi-Cal only population, but I think there will be more federal dollars put into the implementation here. But I think that's something that we should all make sure happens.
I too took out of this that the in-person, high-touch approach is really what's needed here, is what I'm hearing. And what I'm wondering is, in your research, did you find places that was happening, or are you just concluding that because it didn't happen and we had problems?
We definitely found that it was happening in certain places. I mean, the issue is it's actually related to how we measure success. Ultimately, we know that this is important. We got the feedback directly that those strategies worked better. They're anecdotal. We got that information back from the plans as well as from the community-based organizations. So people know this. What's not bearing out right now is the influence on the numbers. So if you look at the chooser rate, it doesn't seem to be influenced by that. But we know from the literature, and we know from other studies that have been done in other states and other experiences, that that number does change over time. And there is a correlation. I mean, the state of Minnesota has had a lot of experience where they have been very clear that they got better results by investing, upfront at the state level in the high-touch communication. They had much higher chooser rates. They had much more stability of the population, much less churn and confusion. And so we're trying to connect those dots right now. But what we would say is that this is really, we're trying to use this as like an intermediate outcome, and it's probably a more appropriate long-term outcome. And we don't really have another proxy for this right now. So we're, trying to tell this story in as best as we can.
Maybe I can give Casey a real life example. When Healthy San Diego started many years ago, we negotiated for the County of San Diego administrative dollars to take a captured a group of folks and give them one-on-one HCO presentations and take them through the health plans, what they offered. Back then, our default rate in San Diego in Medi-Cal managed care was in the single digits. Today, it's 33%, because everything comes out of 1-800 we don't answer.
This is the disability community with some very specific access needs. And I didn't see anything in there about what are the experiences of providing services to this population in an accessible way.
Well, I think that you're raising, an extremely important point, and that's actually, when Chris was describing the three-pronged approach that the foundation is taking to studying this, the next piece of this is a beneficiary survey. and that is focusing on, essentially the beneficiary experience. And so that is going to be very important information and very important feedback, because we, through our design and kind of the way that this, the scope of this project, we did not talk to any consumer groups. We talked to different disability advocate groups. I mean, I shouldn't say that we didn't talk to any consumer groups. We did not talk to consumers directly, beneficiaries directly. We spoke with the groups and that kind of thing, and we were really trying to look at in each of the communities the relationships and what was done. I mean, basically, what were how did they work with the health plans? What were the issues? And we did hear about issues, and those are definitely going to be documented in the report. Today we really focused on presenting the survey results, so you're not seeing any of that kind of narrative. And we also, through the survey, did actually get some very good feedback about the implications of, kind of the ripple effect of this, where people were identifying some specific issues, and we will have those anecdotes in the report. And I say anecdote not critically, but just that kind of is what it is. I mean, we had 100 entities responding and that sort of thing. But our goal is to really be able to give that flavor, and hopefully you will be able to see a bit of that perspective encompassed in the report. But it's going to be most meaningful when it's then coupled with the second piece of this, which is the beneficiary survey. Again, in our site visits, we did talk to some providers. What was interesting is that we did get examples of the accommodations and the work that they've been doing. What was interesting, though, was that the issue that was raised most frequently where they did not feel prepared was in dealing with people with mental illness and mental health issues, and they felt very ill-prepared. And that was actually true of the health plans, where there was actually, when Bobby and I asked these questions, that issue was discussed more so than some of the other conditions. So it's just, we were really kind of, again, we're taking a temperature. I mean, this is, I won't call this quick and dirty, but we were not going deeply into each of the communities and doing that level of it. But so it was really taking the temperature, and I think that's where these issues are very important.
I think we have time for one more question.
Chris, I just want to add to that. Just in San Diego, we tried our best. I listened to every word you said, and we tried our very best, and I think this is an important issue, especially when it comes to like the mental health providers. We trained almost all of them through the county mental health system, and mainly because there was going to be a lot of changes. A lot of their clients live in board and cares and independent living facilities. A lot of these facilities have doctors who won't work with Medi-Cal managed cares, who come out every single month and do a complete H&P on every single member, whether they're young and healthy or not. And things are going to change. And we additionally reached out in San Diego. We have an independent living facility collaborative. And so we reached out and took our Medi-Cal Managed Care 101 presentation to them so that they're aware, they know who to contact. Part of the presentation is a key contact person at each health plan, so that when they go through member services, they go through referral process, whatever, if something doesn't work, they have a person to call. And so, but I heard every word you said loud and clear. It's very important information. Thank you.
And I apologize to those of you whose questions we didn't get to, but feel free to come up afterwards and engage any of us with your question or your comment. I want to wrap things up now and thank again, first, all of you for joining us, and boy, the badge of honor for those of you who stayed extra to participate in this discussion. So thank you. Again, a reminder, please do, particularly those of you here, complete your evaluations. And I want to thank Bobby and Karen for their terrific presentation of the findings. I think the discussion that we had here today will really help them with finalizing the report and answering making sure they address your questions and comments in the report itself. You can anticipate that report coming out. It'll probably be several weeks before we're ready to publish that, but please be on the lookout for that. And if you're not already on our mailing list, please do sign up. And then, of course, our panelists, Greg and George, for taking time to travel up here from San Diego and share their perspectives on this. Very much appreciate the effort, both in coming up here and in your comments as well. And Margaret, not just for participating on today's panel, always hard for the department to take the heat, but in partnering with us in the study. These studies like this cannot happen without some participation and some cooperation and collaboration from the department. So I want to thank Margaret, both on behalf of the department, but her individually as well, for helping us to make this happen. And then last, Brenda, who's one of the only advisory group members who participated on this study, who's here today with us. But thank the entire advisory group who helped help us shepherd this study through and help design the questions. So thank you all.